tertiary prevention programs, we are trying to increase access to treatment. Very effective treatment for opioid use disorder is medication-assisted treatment, and we're going to go through that a little bit as well. So this is just kind of an overview. This is not an exhaustive list of every single strategy we're implementing, but a brief overview of some of the recent funding we've gotten from the federal government to combat the opioid epidemic. So I mentioned harm reduction, and I just want to go through that for a minute before continuing. Harm reduction, another word for that you may have heard, if you haven't heard of harm reduction, would be risk reduction. And this is really just any strategy or ideal that can reduce the negative consequences of a behavior while someone is continuing to engage in that behavior. So I have some examples related to drug use, but this is not only a drug use related strategy. So driving is a very dangerous activity. Tens of thousands of people die in car accidents every year. Wearing seatbelts, following the speed limit, and stopping at stop signs are all harm reduction measures. So driving is very dangerous, but there are things we can do to make it safer while we continue to drive, because we're not just going to all stop driving cars. Having fire extinguishers in your house or in an area where a fire might be more likely to occur is a harm reduction measure. Wearing sunscreen if you're going to go out in the sun or go to the beach is a harm reduction measure. Instead of saying you can't go in the sun, you might get skin cancer, making sure that you wear sunscreen, maybe wearing a hat, staying in the shade, all of those are harm reduction measures. So as it relates to drug use, there are also some harm reduction measures. Abstinence is harm reduction at its core. However, we know that not everybody is abstinent from drugs, and we need some strategies for people who have been using drugs, who can't stop, who aren't stopping anytime soon, to keep it as safe as possible until they are ready for treatment or successful at a treatment program. So needle exchange programs are one of those strategies. There is one program in Miami-Dade County. These programs exchange used needles for sterile, clean syringes for people who inject drugs. They also provide HIV and hepatitis C testing. They link people to HIV and hepatitis C treatment who do test positive. They also link people to drug treatment. So people have a safe space to go in the community when they are ready for treatment, where they're receiving non-judgmental services, and they can be linked to drug treatment from that point. So it does serve as a good referral source for people to get all other kinds of care aside from just reducing, HIV or exchanging clean needles. Increasing access to Naloxone among people at risk of overdose is another harm reduction strategy. So this is not encouraging people to use drugs or letting them know it's okay to be using drugs or sending the wrong message, but we are acknowledging that we know people are using opioids and dying of overdose deaths whether or not Naloxone is available. And when we make Naloxone available in settings where it's likely that an overdose is to occur, we know that we can save lives, and that is what we're going to be talking about today. Medication-assisted treatment is another form of a harm reduction strategy for opioid use disorder. So this would be providing, there's methadone, buprenorphine, or buprenorphine naloxone combinations such as Suboxone, naltrexone, and Vivitrol. These are all different kinds of medications that can reduce cravings, withdrawal symptoms, help people focus on other things going on in their life, get to the root of why they're using drugs in the first place, and have been proven to be very, very effective at reducing overdose risk, saving lives, and reducing injection drug use among participants, so that reduces HIV and hepatitis C. There is still a lot of stigma associated with these kinds of treatment modalities. Some people think you're replacing one drug for another, but really we don't think about that with other kinds of medical diseases, like an opioid use disorder. If someone has to take blood pressure medication every single day for the rest of their life, are they dependent on blood pressure medication? Yes. If they don't take it, they're going to have issues with their body. But we wouldn't look at them and say that they're addicted to blood pressure medication because they have to take it every day. There's still a lot of stigma associated with medication-assisted treatment, viewing it as substituting one drug for another or replacing one addiction for another, when in reality, it does improve somebody's functioning very well, and if somebody's doing very well on a substance that is part of their treatment modality coupled with counseling and other social support services, we shouldn't be compelling them to get off. If it is a decision between the client and the physician that they don't want to be on this medication anymore or they want to try something else, that's perfectly fine. We just want to offer all options and all tools to individuals and have them make informed decisions for their care. Residential treatment and detox are part of that as well. So getting into naloxone, that was just an overview of some of our strategies, but now we're going to get really into naloxone and how to reverse an overdose and recognize an overdose and some of the laws in Florida related to this. So naloxone hydrochloride is the generic name of the medication that reverses opiate overdoses. So those overdoses caused by heroin, prescription pain medication, fentanyl, etc. Narcan nasal spray is a brand name version of naloxone, and that is one of the nasal spray products. Narcan is the product that DCF does have available, so I may use those interchangeably. I'm going to train you specifically on Narcan nasal spray since that is what we have available. But when I'm talking about naloxone generally, this applies to all naloxone products. It's the same medication in all of these devices, maybe just a different dose. But it's an FDA-approved prescription medication. It's not a controlled substance. It is prescribed. It's been used by EMS for 40 to 50 years, so this is not a new medication. This has been used to reverse opiate overdoses for 40 or 50 years. The newer part about it is increasing access to naloxone among people who are not traditional medical personnel, so lay people in the community, people like me and you who might know somebody with an opioid use disorder or know somebody who uses opioids or is at risk of overdose, and people at risk of overdose themselves, increasing access to anyone who might witness or experiencing an overdose. So it's very similar to an EpiPen, but for opiate overdose. You don't have to be a medical professional to administer an EpiPen to somebody. And you would want anybody at risk to have access to an EpiPen. So it's very similar to naloxone. It's an opioid antagonist, and we're going to see how that interacts, but basically it blocks opioids in your brain, so that is what reverses the overdose. This only works on opioid overdoses, so it has no interaction with other types of drug overdoses. So if somebody is experiencing alcohol poisoning or cocaine overdose or Xanax overdose or anything else, naloxone is not going to do anything to help this individual. The good thing about naloxone is that it's such a safe medication, you can administer it to someone when you don't know what they took. If you discover someone who you might not know and it looks like they've overdosed and you can assess them, you can administer naloxone and call 911. If it's not an opiate overdose, you did not harm this individual. You did not help them at all. I mean, it's not going to do anything for a different type of drug overdose. The person needs other medical assistance, or if it's a different medical condition, naloxone is not going to help revive this individual. But if they have opiates in their system, naloxone could save their life. Again, also, a lot of drug overdoses are a combination of substances. So if it's heroin plus alcohol that caused an overdose and you administer naloxone to someone, it could reverse the heroin portion of that overdose. It won't do anything for the alcohol that would still be in their system, but if the combination of substances caused them to overdose, then they could be revived. I also just wanted to clarify that this is not medication-assisted treatment. Sometimes people confuse naloxone with naltrexone or Vivitrol, which is either an oral medication you would take every day or a once-a-month injection that lasts for 30 days, and that's a complete opioid blocker. It's also an antagonist. However, that is for the treatment of opioid use disorder. Naloxone is just an emergency treatment for opiate overdose. So I just wanted to clarify, this is not treating opioid use disorder. This is treating an acute emergency situation that is an overdose. So naloxone can begin to work to revive someone within 2 to 3 minutes. We're going to get into, maybe needing to administer multiple doses, but it is common practice to wait a few minutes between each naloxone dose if you do have to administer multiple doses. So it may work, it should work within 2 to 3 minutes, but we're going to get into why it's not always just one dose that you might need. It really depends on what somebody ingested, when they started overdosing, when they were discovered, when they were administered naloxone, all their tolerance, various factors. It lasts for 30 to 90 minutes once it does revive somebody. So it's a short-acting medication. There are opiates that could outlast naloxone. For example, methadone is a very long-acting opiate. So when you do administer naloxone to someone, if they are revived, don't leave that person alone. really they should be in the hospital and 911 should have been called, and they would be monitored in the hospital for at least a number of hours to ensure that they don't slip back into an overdose once naloxone wears off. Naloxone, since it is an opioid antagonist, it does put somebody into withdrawal who is dependent on opioids. It's a very unpleasant experience, and I do not say that lightly, for someone who uses opiates on a daily basis. If you have an opioid use disorder, you avoid going through withdrawal on a daily basis. It's similar to, I know that people have done a lot of things when they have an opioid use disorder or a substance use disorder that someone who does not have that disease can't understand why someone is doing. But it's similar to if you're starving and you haven't had food in X number of days, you're probably going to do a lot of things that you never thought you would do to be able to eat. It's very similar to that for an opioid use disorder or a substance use disorder. You will do things that you wouldn't have normally done, but you're avoiding going in withdrawal on a daily basis. So naloxone does put people into withdrawal when you are revived. It's a very unpleasant experience. Withdrawal symptoms could range, they're basically flu-like symptoms, but again, I don't say that lightly. So throwing up, severe pain, fever, chills, it's a very unpleasant situation for anyone being revived with naloxone. It does save somebody's life, so it's necessary to administer naloxone to someone who's overdosing so that they don't die, but it's a very unpleasant experience for someone to go through. So there are a number of different naloxone products available. Again, I'm going to teach you guys about the Narcan nasal spray because that is the product that DCF does have available for organizations, but I just wanted to show you the different naloxone products available. So the top right is the Narcan nasal spray. That is a brand name nasal spray. The top left is a generic version of the nasal spray. This is commonly used by EMTs and EMS, and they can also convert it to an intravenous medication if they need to. The bottom left is a generic intramuscular medication. It comes with vials of naloxone and intramuscular syringes that you would administer into like the shoulder or the thigh of the person, getting it into a muscle. And then the bottom right is the Abzio auto-injector, which has a retractable needle. It's also intramuscular, so you also administer that into the shoulder or the thigh, but it's the brand name version of the intramuscular product. So I have a couple more images of the Narcan nasal spray since that is what DCF does have available. It comes in this box that's featured on the top right corner, and there's 2 doses in each box. And for any naloxone product you would be getting, there are always 2 doses in each naloxone kit, as they're commonly called, because 1 dose might not be enough. 2 doses might not be enough, but they at least come with 2 doses. So the top right corner is the box that it comes in, and you can see the little device. These are single-use devices, each with 1 dose of 4 milligrams of Narcan. So there are 2 of these devices, each a single dose, that come in the box. They're both individually packaged in the top left corner that you can see, and they come with, you can see a folded up paper in there which has a quick start guide with instructions on how to use the product and respond to an overdose. The box that it comes in also has instructions already printed on it, so there's not extra labeling regarding instructions for use or contents of the medication. The top portion, if you look at the bottom right corner, is the nozzle. That is what gets actually inserted into someone's nostril when you're ready to administer the medication. And then the plunger is the bottom piece right here that you would press up with your thumb, as you can see in the bottom left picture, and that releases the medication. The one thing, you do not spray this medication until you are ready to administer it. So there's no testing of the medication that needs to occur before you're ready to administer it. If you did test it, then it would waste the entire medication, so do not administer it until it's in someone's nostril and you're ready to give them Narcan. So what is happening when you ingest opioids and how naloxone interacts with that? Basically, you have certain receptors in your brain called mu receptors, and when you ingest opioids, they specifically seek out those receptors and bind to them, as you can see in this image, or occupy those brain receptors. So it's similar to a key fitting into a lock. They specifically occupy these brain receptors. the more of these receptors that become occupied with opioids, the more effects you're going to feel. So initially pain relief, but the more you take it would be intoxication. Eventually, what happens in an overdose situation is respiratory depression. Respiratory depression is when someone's breathing gets very shallow. Eventually, they would stop breathing, so they're not getting any oxygen. And that is what can result in death, or what would result in death in an opiate overdose, is respiratory depression, lack of oxygen, and then somebody can die. So we want to administer naloxone as quickly as possible, intervene as quickly as possible to make sure that this person gets oxygen as soon as possible. Because every second somebody is not getting oxygen is critical. Even if we are able to reverse their overdose, someone could still have brain damage from a lack of oxygen for a certain amount of time. So this is what it looks like when opioids are occupying your brain receptors, but when naloxone is administered, again, it's an opioid antagonist. So naloxone goes to those same brain receptors, but it kicks the opioids off of those brain receptors. And naloxone occupies those brain receptors instead. So it doesn't allow the opioids to sit on those brain receptors, and you lose those effects that you were receiving from opiates. So that is what reverses somebody's overdose. Naloxone goes in, binds to the exact same brain receptors that opiates are bound to, and it kicks them off, and it occupies them instead and blocks them from reattaching. That is what reverses somebody's overdose and allows them to start breathing again. Again, naloxone lasts for 30 to 90 minutes. It's not every single time that someone slips back into an overdose, but it's possible that once naloxone wears off, if the opioids are still in somebody's system because they're long-acting, that they could just reattach to someone's receptor once naloxone leaves their system. That does not happen every time, but it happens sometimes, and so it's another reason why someone should be in the hospital and monitored to make sure that they're okay for at least a number of hours, if not longer, or referred or linked to treatment. So there are a couple pieces of legislation that are in Florida statute I want to go over related to drug overdoses. The first one is a 911 Good Samaritan Act. Basically, this reduces some barriers to seeking help when a drug overdose is occurring. So in Florida, someone who's experiencing a drug overdose and in need of medical assistance, and somebody who seeks help for that individual, if they call 911 or summon EMS to the scene, those two individuals cannot be charged, prosecuted, or otherwise penalized for possession of a controlled substance, which is possession of illegal drugs, if the substances were discovered because the person was seeking help. So there are some limitations to that statute, but that is supposed to encourage more people to call for help. And the reason that I think at this point all 50 states have some form of the Good Samaritan law is because studies were done that showed the majority of overdose situations, somebody is there to intervene and call for help. But what they found was that 50% of the time, nobody was calling for help. And the number one reason that people were not calling for help was fear of police involvement or fear of arrest. So we don't want somebody to be scared of getting arrested and having to weigh that when somebody is dying. It is a life or death situation. You should not have to think twice or hesitate to call 911 to save somebody's life. So these types of laws seek to provide limited protections in a specific situation during an overdose where you won't get in trouble if you call 911 acting in good faith to save someone's life, even if there are illegal drugs at the scene. There are some limitations to Florida's Good Samaritan law. It does not provide protections for drug paraphernalia. It does not provide protections from arrest. People on probation or parole are also not provided those protections. However, I've spoken with many law enforcement departments throughout the state, and it's common policy for many law enforcement departments to not arrest anyone at the scene of an overdose. Many law enforcement departments are starting to also carry naloxone, so not only will they not arrest somebody at the scene of an overdose, but they also carry Narcan, and they might arrive at an overdose before EMS. So it's even more of a reason to call 911 is to get naloxone administered as quickly as possible, get this individual in a hospital, and you're not going to get in trouble. So we are trying to spread awareness about that law. It passed in 2012, and I think the knowledge of it is a little inconsistent when I've spoken to many different departments as well as citizens about the fact that this law does exist in Florida. The other piece of legislation is the Emergency Treatment and Recovery Act, and that is our Naloxone statute in Florida. So Naloxone is a prescription medication. It was never illegal to prescribe. If you're an authorized healthcare practitioner able to prescribe medications, you were allowed to prescribe Naloxone. However, people were hesitant to do so unless specific liability protections were offered for prescribing or dispensing Naloxone. So in 2015, Florida passed a law that did allow for people who can prescribe medications in Florida, so authorized healthcare practitioners, to prescribe medication or to prescribe Naloxone to someone at risk of witnessing or experiencing an overdose. That's a little interesting. So you can prescribe it directly to someone at risk of experiencing an overdose. So someone who is also prescribed pain medication who might accidentally overdose can be given a co-prescription of Naloxone. However, you cannot administer Naloxone to yourself, so you need to also make sure that people around the individual who might overdose have access to Naloxone as well, similar to an EpiPen. So the law did allow for third-party prescription, which means that a physician or a prescriber can prescribe Naloxone to me if I say that my sister has an opioid use disorder and I'm worried she might overdose. I can be prescribed Naloxone. It's my prescription, knowing that I'm going to use it on her in case she overdoses. So prescribing a medication to someone who it is not intended for. So the law did allow for that, and it offers civil and criminal liability protections to the prescribers for prescribing Naloxone in that manner and to pharmacists who dispense it in that manner. It also authorized emergency responders such as law enforcement, as well as patients, caregivers, and bystanders, lay people in the community basically, who may witness an overdose. It authorized them to possess Naloxone pursuant to a prescription, store it, and administer it to someone who they believe in good faith is overdosing, and that's key. The law did get expanded in 2016 because when it is only available through a direct prescription from a prescriber, virtually nobody has access to that medication. There's a lot of stigma still with providing access to Naloxone, especially among the prescribing community. If it is appearing to encourage or acknowledge that your patient is using illegal drugs, then a lot of the times it's not prescribed. It's very difficult to get a prescription for Naloxone directly from a prescriber. Plus, you also have to have a prescriber and have health insurance and be in the healthcare system, which a lot of people are not. DCF primarily serves, underinsured, indigent, and uninsured individuals. So that is certainly a challenge. So it was expanded in 2016 to allow pharmacies to dispense Naloxone to people without a prescription. What that means, I say without a prescription, but it really is a policy that a prescriber would sign for the pharmacy that says people who come into this pharmacy and ask for Naloxone or meet this criteria, and they can come up with a list of criteria, whether it's people who were recently released from prison, people who, were just discharged from drug treatment, all kinds of, anyone who's given an opiate prescription, anyone who asks for Naloxone. It can be very expansive. That policy is called a non-patient specific standing order, meaning the doctor who signs it is not seeing each of these patients. Similar to like CVS administering flu shots to the public, that's kind of a standing order. So this allows for somebody to go into a pharmacy and directly ask the pharmacist for Naloxone without needing a prescription from their doctor first. So that does help to reduce some barriers. Not every pharmacy in Florida is operating under that policy. It's voluntary. All CVS pharmacies and all Walgreens pharmacies are operating under a Naloxone standing order. So you can go into any CVS and Walgreens pharmacy, go to the pharmacist, and ask for Naloxone. There are some issues with that. Not every pharmacist is aware that happens to be working that day, so we've certainly heard some issues with somebody going to a pharmacy and the person saying, no, you need a prescription, when actually they are operating under a standing order and there's some confusion. They don't always have Naloxone in stock when you ask for it, so you might have to call ahead and order it first. If you do not have insurance, it's virtually unattainable. It can range anywhere from $60 to $250 out of pocket without insurance. So we know that people are not going to be able to access that. With insurance, there are many insurances that do cover some form of naloxone. So if you do have insurance and you're able to call the pharmacy, I would advise calling the pharmacy first. If you are going to test this out or you do want to access a naloxone kit to have on hand just in case for you or for somebody else, call the pharmacy first to save yourself a trip over there. Ask them if they have naloxone in stock. Ask them if you need a prescription for naloxone, which means are they operating under a standing order policy. Ask them how much it will cost with your insurance. And if all of that, if you still want a naloxone kit after being able to afford it or your insurance covers it and it's $0 copay, request a naloxone kit and ask them when you can pick it up, because sometimes they don't have it in stock, but they will order it for you and have it available within 24 hours or within a day or two. So if you are going to test out that policy, again, CVS and Walgreens pharmacies are operating under that, and just call ahead and make sure. The Surgeon General also, the governor recently did declare a public health emergency in combination with the state Surgeon General in Florida. So Governor Scott declared a public health emergency, which allowed DCF to start using some of our federal funding a lot more quickly than we would have been able to do to respond to the opioid crisis and implement a lot of these programs, including our naloxone program. And the Surgeon General also issued a statewide naloxone standing order for law enforcement. So what that means is that any pharmacy in the state now is able to dispense naloxone to a law enforcement officer without a prescription. I do not believe that applies to the general public. The CVS and the Walgreens pharmacies do apply to the general public. So we basically know that a lot of people still do not have access to naloxone, even having to go to a pharmacy or paying any copay or waiting in line at the pharmacy or going there and then realizing they don't have it in stock and having to come back. All of these are barriers to access to naloxone, and we want to make sure that in an emergency situation this is available. And we need to make sure that people have it in their hands before an emergency occurs. Once an overdose is already occurring, it's way too late to try and get access to naloxone. At that point, I mean, you know, you call 911, they have naloxone as well. But we want to make sure that people have it to administer to someone as quickly as possible. To still call 911, it does not replace calling 911, and there are many reasons for that. But with some of the stronger substances that we are seeing with fentanyl, with fentanyl, which can be hundreds or thousands of times stronger than regular heroin and cause an overdose a lot quicker, we have less time to intervene to save somebody's life than we used to sometimes. So true first responders in these situations are the people who are already at the scene of an overdose who have to call 911. That could be people who use drugs who are at the scene. It could be family members who discover the individual. So we want to make sure that they have naloxone so they can administer it while EMS is on the way. And when EMS arrives, you would let them know that you gave the person naloxone, and we go from there. So I want to go through a couple risk factors for overdose to begin with. Mixing different types of drugs, as we discussed, is one of those risk factors. So a combination of substances, it could be uppers and downers, and people may think that it cancels each other out like heroin or alcohol or heroin and cocaine, or people seek that out specifically to get that rush of combination of substances. That is a risk factor for overdose. If someone is going to do that, I would just advise that you use a little bit less of each substance. Again, total abstinence is ideal, but in the environment that we are currently in with an opiate epidemic, we know that telling people, like, just don't mix drugs together isn't going to resonate with a lot of people who are going to mix drugs, regardless of what you say. So we need to come up with and inform people of some other risk reduction strategies, since we know what they're doing, to make it a little bit safer until they are ready to get into treatment or they are ready to, be successful at treatment. Again, a lot of these people have also been in treatment like 10 or 15 times, so we need to meet people where they're at, which is the concept of harm reduction. Instead of telling someone what we think they need to be doing, listening to them and asking what they need from us that day. The quality of the drug is another huge risk factor for overdose, and that mostly pertains to street drugs. So, We did have a very bad pill mill epidemic in Florida especially, and across the nation, where people were overprescribing a lot of pain medication. So you had a lot of people who got dependent on pain medication. We did shut down a lot of pill mills, but we, developed a lot of opioid use disorders through that. So then people's prescriptions are cut off, and we did have, we have a lot of people who have turned to heroin, which is a lot more dangerous, mostly because you don't know what's in it. When you're getting it from a street environment, you're not testing your substance. It has not been FDA regulated. You don't know the dose. You don't have to be ID'd or under any care of a physician. I mean, it's really, you don't know what you're getting, and that is what we're starting to see a rise in overdose deaths from, is heroin being laced with or cut with fentanyl and carfentanil and some of these other synthetic opioid analogs that you can't tell by looking at the substance what's in it, but it is much stronger. Having a low tolerance as well is a huge risk factor for overdose. And so when I say that, when you are using drugs on a daily basis, you build up a tolerance to it. So you don't need as much of a substance, or you're going to need more of a substance to get the same effect the more often you use it. The first time you use heroin, let's say, you're not going to need as much of it to get high or to get pain relief. But the more often you use it, it's going to take more and more of that substance. You build up a tolerance to it. When you stop using drugs, such as opioids, for even a few days or a few months or a few years, your tolerance gets really low and can become non-existent to what it used to be. So we know that if someone is going through abstinence-based drug treatment, they haven't used drugs in 30 days or 60 days or 90 days or a few years, if somebody relapses when they're discharged from treatment or complete treatment, the risk of overdose is very high, and we see a lot of overdose deaths from that. And that's very troubling. We also see it when people are released from jail or prison. If they were previously using opiates before they were in the criminal justice system, and then they get released and they relapse, then we see a high rate of overdose from that. We also see a lot of people relapsing, so it's not just a small number of cases where somebody relapses after treatment. We see a high rate of relapse from abstinence-based treatment for people with opioid use disorder. It is common for people to relapse. I mean, it's similar to being on a diet. Are you going to be successful at being on your diet the first time you ever do it? Probably not. You can have cheat days. You can, accidentally eat, a cookie and then make up for it later and go to the gym. I mean, there's all kinds of, little setbacks, but with an opioid use disorder, that can result in death. So we do want to make sure that anyone being discharged from drug treatment or enrolled in treatment or released from jail or prison or actively using drugs or given an opiate prescription, and the friends and family members of those individuals as well, have access to Naloxone in case this were to occur. We're not encouraging it, but we are acknowledging that it's happening. And if we make this available, we do have an opportunity to save someone's life. Using alone would be another risk factor for overdose. So what that means is basically using behind a locked door. If nobody knows that you are using drugs, or if you've relapsed and are ashamed and do not want to let people know you've relapsed, there's still a lot of stigma associated with, having an opiate use disorder, and everyone can be very proud of you because you went to treatment, and if you relapse, it's people are very ashamed to admit that to close friends or family. So if nobody knows to check up on you or to be around or to administer Naloxone, then nobody's going to be able to call 911. So that's what we mean when we say using alone. So some of the signs of an opioid overdose, the main thing is that someone is unresponsive. This can mimic other medical conditions. So again, if you administer Naloxone to someone who's not overdosing on opioids, no harm done. It's not going to help them. They do need other medical assistance. But the main thing is that someone is unresponsive. They are not going to be responsive to stimuli or shouting their name. They could have blue skin, lips, or nails from the lack of oxygen. Their heartbeat can be very slow. Their pupils can be very small. They might not be breathing, which is the respiratory depression we talked about. Or it could sound like they're snoring. And I've heard of way too many situations where someone thought someone was sleeping, and they were like, oh, I checked on her a couple hours ago and she was snoring, and I came back and she was dead, and we called 911, but it was too late. That means the person was not snoring. It was a death rattle, which sounds like someone is snoring or gurgling, but really they're not getting any oxygen, and that's a sign of overdosing. So the main thing, though, is that they're unresponsive. And that's the difference between when to administer naloxone to someone and when not to. If someone is just very high and nodding in and out, but they are still responsive, you do not administer naloxone to them. Don't leave them alone, and, you know, they may start overdosing. But you administer naloxone when someone is unresponsive. They are unconscious. They are not responding to you trying to wake them up. So that's kind of the difference between, do we just administer it to someone we think is going to overdose? No. You only administer it to someone who's definitely not responsive. And the reason we want to provide this education, especially to people who might overdose themselves or have friends that overdose, and friends and family members and drug treatment center staff and all kinds of first responders, is because sometimes people in the community resort to some of these other methods to wake someone up from an overdose, and these do not work. They waste time. They're not getting people oxygen, which is what they need. And essentially, it's sometimes what people do because they're too scared to call for help. So they might let their friends sleep it off, thinking, you know, oh, they're fine. This, you know, this happens all the time. They'll be fine. And they try to let their friends sleep it off, and the person dies. They'll try to wake them up by putting them in a cold bath or shower, putting ice on them, trying to make them throw up, punching them, or, you know, really just trying to, like, jolt the person into waking up, giving them other substances like salt water or milk or caffeine. None of these things work. You should not be giving someone other drugs when they're already overdosing, except for naloxone. So we want to teach people not to do any of these things, instead teach them what they should be doing, and a lot of this just wastes a lot of time. Even if somebody ends up calling 911, we don't want them to wait until the last minute to call 911. We want someone to immediately call 911 as soon as an overdose occurs. So if you try these other methods and then eventually you're like, okay, we need to call 911, it might be too late by that time. By the time EMS get there and the time you actually called 911, it could be way too late to revive this individual. We see people, you know, dropping their friends off at the emergency department because they're still too scared to call 911 and are trying to get their friend help without trying to get in trouble. And I understand that. We don't want people to be afraid to call for help in a life or death situation. So we do want to teach the appropriate response to an opiate overdose. And I'm going to go through each of these steps. The first thing is to do a sternal rub to check for responsiveness. You would call 911 if the person is not responsive, administer naloxone and do rescue breathing or CPR, and put the person in the recovery position. We're going to go through each of these steps. So doing a sternal rub to check for responsiveness. The person can be laying on their back, make sure nothing is in their mouth or their throat, blocking their air passage. And as pictured on the screen, you make a fist with your hand and you would rub your knuckles up and down the person's chest bone or their sternum, as it's pictured on the screen there. You do this for about 5 to 10 seconds, and if somebody does not wake up from that, you call 911 immediately. It does hurt. I mean, you do not punch someone or anything, but you do put your weight into it and you rub your knuckles up and down the chest bone. If you do it to yourself right now, you can feel that it hurts. You would hope that someone wakes up and they're like, what are you doing? I was sleeping. And you're like, okay, great. You are not overdosing. If someone does not wake up from a sternal rub, they are unconscious and you call 911. If there's multiple people at the scene, I mean, someone could be doing a sternal rub while someone else is calling 911, while someone else is preparing naloxone. So this is just a very quick way to check for responsiveness and replaces like putting someone in a cold shower or making them walk around, all of those things that waste a lot of time. This is very quick. They don't wake up, call 911, administer naloxone, do rescue breathing. So you would call 911, let them know somebody is not breathing and needs medical assistance, and give them the address of where you are, and stay on the phone with them. So administering naloxone, and this is the Narcan nasal spray we have available, pictured on the screen here. Someone would be laying on their back. You would administer the nozzle into one of the nostrils, it doesn't matter which one, and press the plunger with your thumb, and that will spray the medication into the person's nose. It's a very, very easy product to use, so really I don't need to spend a lot of time training you how to actually use the Narcan. We really wanted to talk about the other steps of responding to an overdose, some of the misconceptions, the laws in Florida, why it's important to increase access to this medication, and all of that. Using the medication itself on this device is very easy. You stick it in somebody's nose and press the plunger down, and it will spray the medication. You might hear a little click, and that means the medication was administered, so it's like a little bit firm. It's hard to accidentally administer the medication. You'd have to really intentionally press that plunger down. It is a nasal spray. It does work to reverse an overdose even if someone's not breathing. Someone probably won't be breathing if they are overdosing. It does still work to reverse an overdose. If someone's not breathing, it gets absorbed into their nasal mucosal membrane. So you would administer one dose of Narcan and then do rescue breathing or CPR. I teach rescue breathing because there is a lot of differing opinions between whether or not to do rescue breathing or CPR to get oxygen into an individual. I am also not certified to teach CPR. So if you are CPR certified, you can do CPR. If you are not or don't know how to do CPR, then do rescue breathing. One of the two. So rescue breathing is pictured on the screen here. Law enforcement typically have protective gear that they can use. Typically people in the community do not. So again, if you don't want to do rescue breathing on someone, then do chest compressions. You would tilt their chin up and pinch the nose and administer 2 quick breaths, and then 1 breath every few seconds. If you're doing rescue breathing correctly, you would see their lungs or their chest rising, meaning you're getting oxygen into their lungs. So this is meant to be done in between doses of naloxone, or right before you administer naloxone. You can give someone a couple quick breaths and then administer Narcan. If there is somebody else at the scene with you, they can be preparing the naloxone while you're doing rescue breathing. There's a couple different avenues there. It's also meant to be done in between doses of naloxone. So you administer 1 dose of Narcan to someone, and you're supposed to wait 2 to 3 minutes for it to work. So in that time, you administer 1 dose, and then you do rescue breathing for 2 to 3 minutes. If they're not revived in 2 to 3 minutes, you give them a 2nd dose of Narcan and go back to doing rescue breathing for 2 to 3 minutes. And that process would be repeated until somebody is revived. Now, when you call 911, it's unlikely you're going to be able to administer multiple doses of Narcan before they arrive at the scene, because they do have very quick response times in most areas. You can put the individual in the recovery position when somebody is revived or in between doses of naloxone if you were not doing rescue breathing, which is pictured here to make sure somebody does not roll over onto their stomach or suffocate. When EMS arrives, let them know that you administered naloxone to this person, whether or not they are revived, because EMS also have naloxone, and so do some law enforcement departments. And that will dictate how much naloxone EMS may need to administer to this person. So you can't overdose on naloxone, but as in you can't die from having too much naloxone or a toxicity from it, but you can administer too much naloxone to the point where it's unnecessary, and we certainly want to avoid that. So that is the reason that you are waiting in between doses to administer additional doses, because you don't want to just immediately administer as much naloxone as you have. That could make someone's withdrawal much more severe. It could cause other issues that we don't want to have. If you make someone's withdrawal much more severe than it needs to be, then it can cause complications. So you have to titrate the dose of naloxone. So you start with 1 dose and you administer 1 every few minutes. The Narcan nasal spray is a much stronger version of naloxone than some of the other products. So it is a highly concentrated dose and it's strong. So I advise waiting the full 3 minutes and in between doses. we do hear of in the community at times, in other states and in other places, like, oh, it took 5 doses of naloxone to revive someone. Sometimes that's accurate. If EMS needed that many doses of other naloxone products to revive someone, that's very possible, and it happens for sure. It depends what somebody took, when they were discovered, their tolerance, all kinds of things. But in the community, you don't want to immediately administer 5 doses of naloxone to someone. Typically, when we hear that, it's that somebody was not waiting enough in between doses to administer it and to let it start working, or it was not an opiate overdose. The FDA advises that if you've gotten up to 10 milligrams of naloxone and do not have a response, that you need to reevaluate if it's a different medical condition. There have certainly been instances where it has taken more than that to revive someone, but again, it's advised to reassess and see if it's actually an opiate overdose or if it's some other drug that is causing the person not to be revived. So again, those are the steps of responding to an overdose. I'm going to leave them up here for 1 minute. So you would do a sternal rep to check for responsiveness, call 911, administer naloxone and perform rescue breathing, and put the person in the recovery position. Let EMS know that you administered naloxone when they arrive, or law enforcement. So some of the misconceptions of increasing access to naloxone or some opposition to it is that it would send the wrong message or encourage people to be using drugs or increase the amount of drugs that they're going to use because they know they can be revived, prevent people from going to treatment, or cause people to be violent when they are revived. So the first 3 things, whether it's sending the wrong message, encouraging drug use, or preventing people from going to treatment, are not true. Access to naloxone among people who use opioids and their friends and family members has been studied since the 90s. So 1994, 1996 is the first program that started providing free access to naloxone among people who use opioids and their friends and family members. So this is new for Florida. Other states have been doing this for like 20 or 30 years. So it's not really a new concept. It's new to our state, but it's been very well studied in other states and other countries. So we know that this does not encourage people to use drugs. There are a couple of reasons for that. I mean, in an opioid use disorder situation, you are using every day to not go through withdrawal. So whether or not naloxone is available is not going to factor into somebody's decision if they're going to use or not. It also, getting Narcan puts somebody into withdrawal, and that is something you are trying to avoid on a daily basis. So you are not aiming to overdose because you know that you can be revived with naloxone, because then you are wasting your drug supply, you are putting yourself in withdrawal on purpose, summoning law enforcement and EMS to your house, and being in the hospital. It is not something that anybody who's actively using drugs is going to do. We do want to make sure they have access to it because we know that people are using drugs, and if they don't have access to naloxone, we see an increased number of deaths. But it does not encourage people to use drugs or increase the amount of a substance that they're going to use. It's very similar to a fire extinguisher, as I mentioned before, as a harm reduction measure. Making sure you have a fire extinguisher in your house does not encourage you to start fires because you know you can put it out with a fire extinguisher. It just makes sure that you have that in case something like that were to occur. Same with seatbelts. They don't encourage people to speed or get in car accidents. It's just a dangerous activity to be driving, especially distracted driving, and we want to make sure people are as safe as possible. It's very similar to safe sex education as well. So we're not encouraging young people to have sex, but we know that if we teach abstinence-only sex education without access to any contraception, we do see higher rates of unintended pregnancies and STDs. We're not encouraging people to engage in that activity, but we do want to provide access to contraception. If people are going to do that, we want them to be as safe as possible instead of pretending like it's not happening. Naloxone also does not prevent people from going to treatment. It could provide as an intervention to encourage someone to go to treatment, but do not be discouraged if someone's been revived multiple times and still has not gone to treatment. I do hear, from the field and anecdotally, someone's been revived 30 times, and on the 30th time they died. And some people like to blame the person who was overdosing that many times for taking up EMS's time, for, using that much naloxone, for not stopping using drugs, but we know that with an opioid use disorder, it's not a choice. It's not a moral failing. It's not someone could just stop using. And if anything, I would look at someone being revived 30 times and eventually dying as a failure on our system and all of our community partners, as well as us, to provide the correct interventions. Clearly, we were not reaching this individual or meeting them where they were at like we should have been if we were reviving someone 30 times and they eventually died. So I would not support, limiting the amount of time someone's able to be revived. It's an emergency situation, and we really don't think of that with any other medical condition. If someone is obese or has heart problems and does not stop eating fast food, and we keep having to revive this individual from a heart attack or provide them with other treatment, as a society, I don't think anyone would ever say, well, you're just doing this to yourself. If you just went on diet, we would not have to keep coming to you, so we're only going to, come to your house 3 times, and on the 4th time, we're not going to come. So we really don't impose that kind of moral judgment on any other medical illness. A lot of people have acknowledged that substance use and opioid use disorder is a disease, but I think there's still a lot of stigma associated with it when you get into these conversations. The other kind of misconception is that reviving someone with naloxone causes them to be violent. People have woken up violent before, but it's really the exception and not the norm in overdose reversal situations. Out of all the reversals that have ever happened, it's not super common. People could be really pissed off. Mostly someone is going to be very disoriented, very confused. They might try to run away because they're scared and wake up with law enforcement and EMS and don't know what's going on. It's possible someone can be violent, but it's really not the most common situation. And it's generally not from the naloxone, but from the environment that somebody might be in and the fact that they're scared and don't really know what's going on. We know that, so just to provide you with some context, providing access to naloxone has been occurring since the 90s among, lay people in the community, people at risk of overdose, their friends and family members. From 1996 to 2014, 26,000 overdose reversals were recorded in the entire nation. And that is not including EMS and law enforcement reversals. That is much higher. EMS use naloxone every day, multiple times a day to reverse overdoses. But that 26,000 overdose reversals is from community members, people who use drugs, people who, are friends and family members of someone with an opioid use disorder, reversing overdoses, saving lives, and reporting it back to a program. That number is certainly much higher. That data is a couple years old, and not every overdose reversal is reported. But we do know that that's at least 26,000 lives that were saved. Where I used to work in North Carolina, we made, and they still do, I don't work there anymore, but they, we would increase access to naloxone for free in the community, and they knew of about 5,000 overdose reversals in just a couple years from their program of increasing free access to naloxone. So we know that it does work to save lives. So DCF's Overdose Prevention Program, we provide free overdose recognition and response training similar to the one that we taught today. We do these in person and through webinars. We provide free Narcan to organizations who will distribute the Narcan they receive to people at risk of witnessing or experiencing an overdose. So some examples of that would be substance abuse treatment centers who are enrolling people or assessing people at risk of overdose to provide Narcan for those individuals to take home. Again, not acknowledging or not encouraging them to relapse or use drugs, but acknowledging that it happens, wanting to make sure that they do have access to Narcan. It might not be for them either. Someone might be offended if they're in treatment and you're offering Narcan to them, if they think that you're indicating that they are going to relapse or are using drugs outside of the program. If you are going to be offering Narcan in that setting, let them know that it's your policy to offer it to everybody. It is a free medication. There's no harm in taking it. You carry it, I carry it on a daily basis just in case I witness an overdose. And we have had a number of times where we have provided Narcan to people through our treatment programs who witnessed an overdose in the community, and they were equipped with Narcan, and they were able to save someone's life. So it is not an indication that they are going to relapse or that they might, but they might witness an overdose, and we want to make sure that they have access to Narcan. People being released from jail or prison who came in from using opiates would be a targeted population to receive Narcan. As far as I know, there's only one jail in Florida, which is Orange County Jail in Orlando, who does provide Narcan to individuals as part of their personal belongings when they are released. Again, people who are assessed to enter treatment upon enrollment or upon discharge from treatment, even if you have people, let's say, on a waiting list who come to a treatment center and there is no spot available and there's a spot the next day, people die of an overdose in the 24 hours that they're waiting for a spot to become available. So if you assess someone, put them on a waiting list, and they're waiting for a spot to become available, make sure that they have access to Narcan. Hospital emergency departments would be another avenue. When people come into the hospital for an opiate overdose, making sure that they do not leave that emergency department without a take-home Narcan kit in their hand, as well as one for their friends and family members. I realize that this is not treating their opioid use disorder. So we are also trying to increase hospital pilot programs, as an example, that would provide much better linkage from the hospital emergency department to a community treatment provider, or start medication-assisted treatment in the hospital when someone's already been in there for an overdose, and link them to a provider upon discharge. Also making sure they have access to Narcan. There are some counties that have community paramedicine programs who go out and check on people in the community who've had previous calls, so providing access to Narcan through that mechanism would be another example. Community-based organizations who provide all kinds of social support services, maybe don't provide treatment, but provide homeless services organizations or HIV organizations or harm reduction groups throughout the state. Providing free access to Naloxone is key. We want to make sure that if somebody does receive a Narcan kit, that it's not a one-time thing if they happen to need more. So it's great if they do receive a take-home kit from their treatment center, but if they're no longer in treatment and if they've used their Narcan kit and they need another one and they're not in treatment, we need to make sure that they have access to that. So community-based organizations would be key for that. Federally qualified health centers, county health departments. These are just some examples of settings where it would make sense to provide access to Naloxone among high-risk populations. And that is what DCF's program is trying to provide, is kind of filling the gap for community access to Naloxone for people who are not going to be able to get it. We've also partnered with law enforcement, so with the Florida Department of Law Enforcement, to provide some funding to them, to partner with the Sheriff's and Police Chiefs Association to equip some local law enforcement departments with Narcan. So if you're interested in that, we have the FDLE contact for you to contact and see if the local law enforcement department can be equipped with Naloxone and selected through that grant program. If you're interested in, if you're a community-based organization or a treatment center or a hospital who's interested in getting free Narcan from DCF to distribute to at-risk people, then you would contact me and we'll send out my information after the webinar. We have an enrollment packet which does include some sample policies. You would have to identify a pharmacy that would receive Naloxone shipments for you, because our state hospital does ship to a pharmacy, but there are other policies where the pharmacy can operate under a standing order to then transfer the Narcan to your organization under a medical prescriber's standing order. So it is still acting as a prescription. It's not just like an over-the-counter medication, because it's not over-the-counter yet, but it is a policy that acts as a blanket prescription for your organization to make Naloxone available to at-risk people that you are seeing. So we do prioritize organizations to receive Narcan from us who will make it available. You can also, if you're making it available in the community, definitely store some Naloxone on site in case you need to respond to an overdose. We also want to make sure that your staff is equipped to respond to an overdose if it happens in the parking lot or the bathroom or, some of those other settings. So certainly keep some of those kits on site, but primarily we do want to make sure that it is actually being provided as a take-home, just-in-case measure first aid kit to those people at risk and their friends and family members. If you host like family groups, support groups, I mean, there's all kinds, sober homes, like there's all kinds of settings. We just listed a few. There is a video that you can show people if you are going to be providing access to Narcan. This is the training that we provide to the providers. Your training does not have to be this in-depth when you provide naloxone to someone. I have trained someone on how to use naloxone when I did a lot of community-based distribution in 5 minutes. If I have 5 minutes with them, I can show them how to use it, tell them it only lasts for 30 to 90 minutes, tell them to call 911. You know, if you might need additional doses. I mean, there's a couple high points to hit. If you have more time with someone, then you can certainly go over like the risk factors for overdose. Then we can provide a copy of our PowerPoint, and you can feel free to use content from it to really go deeper into the education of the laws in Florida, the Good Samaritan law, all of that kind of stuff. So the education provided to people can vary depending on how much time you have with someone in the setting. For treatment centers, you can make it, you know, one of the classes that you're teaching is a relapse prevention or an overdose prevention class. You know, if you're hosting support groups for family members, that would be one as well. These are just some examples of other state posters, which we are hoping to also develop that show, you know, access to naloxone maybe in pharmacies or in other community-based organizations that would be providing access to it to let people know that it is available. You can't just have it and expect people to be asking for it. You would have to educate them on why it's important to have access to it and how to use it, et cetera. So I'm going to put my contact information up here. So we can also, I believe, through FATA, send out our Narcan enrollment packet to all of the participants after the webinar. That does have our sample policies in it for a pharmacy to dispense or for a treatment or for an organization to make naloxone available to people at risk. We do require monthly reports. So if you are receiving Narcan from DCF to distribute in the community, we ask that those organizations submit monthly reports, non-client specific, just with how many kits that they have distributed and if they've heard of any overdose reversals. That gets a little tricky. It's not required that someone reports that they used it to reverse an overdose. Really, the only incentive somebody in the community has to report back to an organization that they used Narcan to reverse an overdose is if they can get another Narcan kit. If you use your kit, you probably might need another one, and that is an incentive for somebody to report. When I did a lot of community-based distribution, we would give out our phone number and be like, call or text us, no personal information required, if you use your naloxone kit and need another one. And people were very willing to do that. And they would tell us a lot of details about the situation, even if we didn't require it, because they trusted us and we were providing free access to naloxone, and we were able to record a lot of those, 5,000 overdose reversals. If they don't have another place to get a follow-up kit, we're likely not going to hear about it. I would not want that to be a barrier to providing access to naloxone because we might not know that they used it. So what we're really looking for is making sure that anyone receiving Narcan from us let us know how many they distribute in the community. If they do hear of overdose reversals from the people they serve, definitely to let us know how many. And for if you use any of the Narcan on site as a staff member or volunteer to reverse an overdose, to let us know that as well. So far, we know of about 65, 70 overdose reversals through our program in the past few months. So that is very promising. I'm sure there's been a lot more, but those are the ones that have been reported back to some of our programs. So I'm going to leave my contact information up here and open it up for questions. If Leanne, you can open it up for questions, or if people are typing questions in the chat box that we can now address.
Wonderful. Thank you, Amanda. That was great. We really appreciate it. And, Amanda, we do have several good questions, Before we get to those, we did have a request early in the presentation. If you could go back and review slide 2, and I think it was maybe specifically 3 as well, where the types, I think it was 3 types of opioids are discussed. If you could review perhaps 2 and 3, and then we'll get right to the questions.
Sure. So slide 2 is on the screen, which is the top 10 leading causes of injury deaths, unintentional injury deaths by the CDC. An unintentional injury death is an accidental death, but they do not like using the term accidental deaths, but these are basically deaths that were not intentional. So this would be car accidents, drowning, drug overdoses. Those are unintentional deaths. So this chart is basically showing that unintentional poisoning is the #1 cause, or unintentional drug overdoses is the #1 cause of accidental death in the United States. This is from 2014. They haven't, as far as I know, they haven't updated this actual table. We do have the numbers showing that it's been, I think now, in 2015 or 2016, it was like 52,000 drug overdose deaths. In 2014, it was about 47,000. So we do know that it's steadily increasing, and we don't expect that to really go down anytime soon. But basically, this chart just shows that the #1 cause of unintentional injury death in the U.S. is drug overdose. The majority of those, about 63% of them, so that's about 30,000 overdoses, involved some type of opioid. And that's why a lot of efforts are focused on opiate overdose prevention, because if it's a mix of substances, you can counteract part of that overdose. The next slide, again, this is not an extensive list of all opiates that are in existence, but there are natural opiates that are grown from opium, and then there's semi-synthetic that are slightly manufactured, like hydromorphone, hydrocodone, and fully synthetic opioids. And they just have different properties as they attach to brain receptors, whether it's an agonist or an actual opiate, but they all produce very similar effects. The strength is what is different. So we've seen with, with hydromorphone, hydrocodone, oxycodone, any prescription medication you'd be getting, they come in different dosages, and you can see the strength of the opiate by looking at the prescription label. In the illegal drug market, when you're buying heroin on the street, if it is laced with a synthetic powder substance, which is also an opiate but is not heroin, it's carfentanil or something much stronger, which is like an elephant's tranquilizer, you're really not going to know what's in it. So it could be 50 to 100 or hundreds of times stronger than what you're used to ingesting. I don't know if I answered that person's question, but I'm happy to elaborate on that if I have not answered that question. But again, this is not an exhaustive list. I just wanted to kind of lay the base for the types of drugs that we're talking about when we talk about opiate overdoses.
Okay, perfect. Thank you.
You're welcome.
I'll go ahead and go into our questions. We have quite a few of them. And you already addressed one of our first ones. You addressed it in your presentation. It came in rather early about the nasal spray, and if a person is not breathing, how would they be able to use the nasal spray? But you already addressed that, I believe.
Yes, it will still work if someone's not breathing. It gets absorbed into their nasal mucosal membrane.
Okay, so the next question is, I understand not to test a spray into the air, but is there a possibility it would need to be primed and therefore require more than one pump to administer the full dose?
Good question. The answer to that is no. So when I said you don't need to test it, I meant that you don't need to prime it or anything like that before you're ready to administer it. So certainly do not prime the medication or do anything with the plunger that administers that until it's in somebody's nostril and you are ready to administer the medication. It is a single-use situation, so when you press that plunger, the entire dose of the medication gets released. So there really is no way and no need to test it before administering it. So this bottom left picture is a little misleading because you would not be testing the medication in the air. I just wanted to show you what it looks like, but that would be happening in somebody's nostril.
Thank you. The next question is, and this question refers to, I think it was like slide 8, when you're talking about the onset of naloxone and the duration and the withdrawal symptoms. The question is, 30 to 90 minutes is a big gap. Is that based on how much overdose or body weight or what?
Yes, so it is quite a gap, and there are a lot of factors that go into it, and I think that's why there is that range. So this is what is FDA approved, is that the duration is 30 to 90 minutes, and that is all naloxone products. This is going to depend on what somebody ingested, the strength of whatever it was they took, their tolerance level to whatever substance they ingested, their body weight, and when they were discovered. So they, you could discover them and administer Narcan, but if you happen to stumble upon them, who knows how long this person's been out. So there's a lot of things that factor into that, and I think that might be why there's that range, and there's not just a set amount of time that it lasts for. So it's, advised and definitely recommended that you would then monitor someone after they are revived, because you want to make sure that once naloxone wears off, someone doesn't slip back into an overdose.
Thank you. Thanks, Amanda. And the next, I have two more questions here. Well, we've got several more questions, but I have two that both seem to have to do with withdrawal. So I thought I would read both the questions to you, and you can address it. The first one is, what happens if they are already in withdrawal? The second question is, and it's from a different person, how long does the withdrawal effect last after the overdose is treated?
So for the first question, I think I'm a little confused. They asked what happens if someone's already in withdrawal. Do they mean what happens if you administer naloxone to someone who's already in withdrawal?
That's all I have, Amanda. The first question was only simply that. What happens if they were already, or excuse me, what happens if they are already in withdrawal? And then the second question was, how long does from another person, how long does the withdrawal effect last after the overdose is treated? So just address that however you like.
So for the first question, how I interpret that question is if you administer naloxone to someone who's already in withdrawal, remember how I said that you only administer naloxone to someone who's unresponsive and unconscious. So you should not be administering naloxone to anyone who's conscious. So if someone's in withdrawal and they're responsive to stimuli, you would not be administering additional doses of Narcan to that individual. If I've interpreted that correctly, if not, please retype it in the chat box. The second question of how long the withdrawal lasts, I really don't know. I've heard very varying situations. Generally, I mean, you're monitored in the hospital for about 4 hours. But, I've heard from some people who actively use opiates that it feels like it lasts forever. Some people, they feel like it lasts for an hour or two. I really think it depends on what somebody's tolerance level was. If you're not dependent on opiates and you accidentally overdose, so like a law enforcement officer who maybe accidentally gets exposed in the field and administered Narcan, they would not experience withdrawal. They have no tolerance to opiates. They're not dependent on it. They just need to get that out of their system. Someone who is dependent on opiates, I really don't know there's not a set time of the withdrawal. I would estimate it at a couple hours, but it's not like a hard time.
Thank you, Amanda. We have another question, and you may have sort of addressed it through the responsive versus unresponsive, but the question is, so while a person is vomiting, you don't administer Narcan. You would wait until they pass out?
Right. So if someone is awake and they're throwing up, you do not administer Narcan to them. Again, the only time you administer Narcan, so that's the difference between somebody being really high or nodding in and out or maybe throwing up from whatever substance they took. or actually being unresponsive. And again, you would check to see if someone is responsive by doing a sternal rub. I'm going to put that on the screen here. Obviously, if someone is actively throwing up and they're awake, you do not need to do a sternal rub on them to check to see if they're unconscious, because you know that they're conscious. So you do not administer Narcan to someone who is awake and maybe they're having other reactions to whatever substance they took and need to call 911 for other medical assistance. They might start overdosing if they were throwing up and then maybe pass out and then begin overdosing, so certainly monitor them, call 911, but you don't administer naloxone to someone until they're actually unresponsive and unconscious.
Thank you. The next question is, are there any measures being considered for licensed professionals, such as a licensed clinical social worker, for example, or someone who carries a certification like the MCAP? Are there any measures being considered for licensed professionals to carry Narcan in their cars to increase opportunity for prevention in the same fashion that those certified for CPR AED carry kits?
Yes, and that is something through our program and through other organizations that they can do. Basically, there's some sample policies where you can have a medical prescriber, as an example, a social service organization or a homeless service organization say, all of our outreach workers are going to be equipped with Narcan in case they're commonly doing street outreach and they might witness an overdose in the field. We want them to be equipped with Narcan to administer to someone in case they witness an overdose while they're doing street outreach. So that would be a type of policy an organization could operate under. It is signed by, for extra liability protections, it should be signed by a medical prescriber. So it does act as a prescription, but for the organization. So it's similar to, I didn't mention this, but we have a number of law enforcement departments administering or equipped with Narcan to administer in the field. And the way that they do that is they have a policy that says, Sarasota County Sheriff's deputies will be equipped with Narcan, and this is when they would administer it to someone in the field. After they've received the training, if they notice somebody overdosing in good faith, they think that they're overdosing, they go through these steps to administer Narcan. That policy is signed by a medical prescriber. So it's like a prescription for the Sarasota County Sheriff's Department to carry Narcan. So other organizations can operate under that policy as well if they're able to get that passed, through their executive boards or have a medical prescriber write that kind of policy for an organization to make sure staff are equipped in case that were to occur. And then to take that a step further, we want to also make sure that if they are witnessing overdoses in the field and serving people at risk of overdose, that they're also able to distribute naloxone to people at risk of overdose.
Thank you, Amanda. The next question, if you're ready, is it safe to use Narcan in pregnancy? That's the first part of the question. Is it safe to use Narcan in pregnancy? And the second question is, do we need to look to see if Narcan has an expiration date?
Two very great questions that I did not touch on. So the pregnant women question. The FDA-approved, any FDA-approved naloxone product, they're all not FDA-approved specifically for pregnant women, which is common for a lot of medications. However, the American Society of Addiction Medicine, Substance Abuse Mental Health Services Administration, every medical, national, and a lot of state organizations, the guidance is if a pregnant woman is overdosing on opiates and is going to die, you administer naloxone and you call 911 and she goes to the hospital. So the risk there is, someone going through repeated withdrawal who's pregnant is not good for their unborn child or their fetus. However, if a pregnant woman is going to die of an overdose, that's also not going to be good for the unborn child. So it's a little trickier of a situation. However, the guidance from all the organizations that increase access to naloxone and deal with addiction medicine is if a pregnant woman is overdosing on opiates and is completely unresponsive, you still administer naloxone to them. This is very important to titrate the naloxone dose in these situations as well, and is why we don't just want to administer really high doses of Narcan to everyone we see. You start with a low dose, and you increase that every few minutes. You do rescue breathing, and you call 911. So the guidance is, you know, if she's going to die from an overdose, to administer naloxone, but make sure she's monitored afterwards.
We have sort of a thank you, Amanda. We have a bit of a follow-up question about Narcan and being left in a car. Is there any concern about Narcan breaking down in the heat if it's left in a car? Do you know?
Yeah, and I forgot to address your other question on the expiration date.
Oh, okay.
So the Narcan products and any naloxone product, also the Narcan nasal spray, are all good for 2 years. So when you get the box of Narcan, on the bottom of the box, it does have the expiration date on there. So if you were distributing it, you know, always check to make sure that, you know, as a pharmacist or whatever, you're not dispensing an expired naloxone product. For the temperature-wise, the guidance for the Narcan nasal spray is to be stored at, I think it's 59 to 77 degrees Fahrenheit or 86 degrees Fahrenheit. However, they are permitted to be exposed to temperatures as high as 104 degrees for up to 6 months. So the guidance by a lot of law enforcement departments, for example, who carry naloxone on them, is to just not leave it in your car overnight. You know, once we get this out into the community, we know that people are not storing their medications specific to FDA guidelines. I mean, I don't know if any of you have, when you picked up a medication from the pharmacy, like made sure that it is stored exactly in that controlled environment. Naloxone is a very burly medication, so we advise that it is stored at that temperature. We do know once it gets out into the community, it's probably not going to be kept at that temperature, but the good thing is that it has been exposed to very high heat and extreme cold, and it still works. There isn't really a risk in, it won't harm someone. So the risk of it being exposed to, you know, extreme heat or extreme cold is that it's less effective to reverse an overdose, which is concerning. So you still call 911, but the good thing about it is you can still administer naloxone to someone. If it's less effective, it's not going to hurt them. It won't work, and that's not a good thing. But you can still administer whatever naloxone you have and call 911, and it probably will still work, to be completely honest, but there's not a harm in administering it to someone. The other thing with that, it's very important for, if you're distributing naloxone to someone to take home, temperature is important, but it's also very important of where they keep it. So if they, like, lock it up in a controlled environment and no one knows where it is or that they have it, no one's going to use it if an overdose occurs. So it's very important to make sure, if you have Narcan, to let people know that you have it and where you keep it if an overdose occurs. If you're at risk for overdose yourself, you know, as an example, and you're homeless or you're constantly using drugs not at the house, you know, you shouldn't leave Narcan at the house where you're not going to have access to it or where people around you would not have access to it. You should keep it on your person and bring it with you. So kind of a case-by-case basis. You should adhere to the temperature storage requirements, but we know a lot of people do not, and you can administer naloxone anyway. It might be less effective. Definitely call 911.
Thank you, Amanda. Another question, if you're ready, is, does a police department need a blanket medical prescription to get naloxone?
So technically, yes. Currently no, but most likely in the future, yeah. So basically, the State Surgeon General issued a standing order back in May, and it got renewed in July for another 60 days, that allows any pharmacy in the state, or authorizes any pharmacy in the state, to dispense naloxone to a law enforcement officer. So that basically acts as a prescription for any law enforcement officer in the state to go to the pharmacy and get it. However, that standing order expires. It may get renewed, so I don't really know when it's going to expire. I think it expires 60 days from July 3rd, but for all I know, it will get renewed. However, to ensure that, in case it does expire, what police departments and sheriff's departments do is have a policy, again, that does act as that blanket prescription for their officers to carry it and administer it, and that is signed by a prescriber. It does not have to be an employee of the police department or sheriff's department. It could be, a lot of the times, it's like the EMS medical director of the county or the fire department. Like, it's a partnership between those organizations, those public safety groups who work together to operate under that medical license to administer naloxone. We have sample policies of that as well, so we can send those out. You really don't have to reinvent the wheel. A lot of them are pretty much the same and just differ with the reporting and, where they keep the medication and stuff. But we're happy to help find a prescriber if you're having issues. But typically, yes, those would be signed by a medical prescriber and kind of act as a prescription for the whole department.
Thank you, Amanda. This is an interesting question. Next, we have one who asks, I work at a laboratory that tests post-mortem samples from numerous districts throughout the state. We also test powders and pills from ME offices. My staff is exposed to opioids. I would like to have Narcan on site in case of an accidental exposure. Can I get it from this program? So far, we have been making it available to, again, law enforcement departments who would be administering it to people in the field and groups who are distributing naloxone to people at risk, and, their staff can be equipped as well. We haven't yet expanded to medical examiner offices. I mean, there are so many settings where people can be equipped with naloxone. Since our main priority is filling the gap for community access, that is what we're mainly focusing on. This is through a grant that's what we were approved to do. However, if you only need 1 or 2 naloxone kits, they are not very expensive for an organization to get. So the Narcan nasal spray, if you're a nonprofit organization, they're $75, which is not super cheap, but if you're only buying 1 or 2 naloxone kits, $75 a kit as protective equipment for the lab, I think would be reasonable to request of the medical examiner's lab. We can certainly look at it, and I've been asked that before. I'm just saying primarily right now, it's the beginning of our program. We're increasing access to the community and among law enforcement. It's something we can look at a later date, but we first need to make sure that we're filling that gap of community access. But we know the people who do sell naloxone, like the pharma reps who sell it. We can make those connections for you so that if you would like to purchase it yourself, you can also purchase it. And if you're only buying 1 or 2 kits, it's not very expensive. Thank you, Amanda.
I'm sorry. I will mention one more thing. Some of the manufacturers also donate products. So if you're a medical examiner's office or something, you can apply to one of the organizations to get free products, a couple kits shipped to you at no cost. So I can set you up with that as well.
Thank you, Amanda. And I think you may have sort of mentioned this when you mentioned a Narcan enrollment packet. But this next question is, how do treatment centers sign up to receive naloxone?
Yes, and I believe I saw that question in the chat, and that's when I got into the fact that we do have a Narcan enrollment packet. So we can, if it's okay with you, Fata, we can send that out to all of the webinar participants, which has the process for enrolling. There's a couple forms that you would fill out, and basically they work directly with me, and I'll put my contact information back up here, and I'm sure we can send it out to all of the participants. There are some sample policies in the Narcan enrollment packet. We don't require organizations to operate under them because every group is different, but we do provide them just in case they do need some sort of policy that they can edit. And they would just let us know what their distribution plan is for who they're going to be providing Narcan to, how many kits that they need, and they would place orders directly to me. So the sign-up process is basically through me, and we can send out our Narcan enrollment packet, which describes the ordering process, the monthly reporting, you know, what their distribution plan is and include some sample policies. Once they identify a pharmacy who would be receiving those shipments, we need a copy of the pharmacy license, and then we're ready to start shipping Narcan to that organization. So basically contact me, and we can get you guys set up.
Thank you, Amanda. And we still have quite a few questions. Well, we've got a few questions left, but I'm going to ask one more, if you're all right with that. Are you ready for your final question?
Sure, you can ask as many as you want. And let me just clarify for the treatment center question. Right now, our Narcan is only available for nonprofit organizations or for-profit groups that contract with one of our managing entities. So for-profit treatment centers or other organizations who don't have a contract with one of DCF's managing entities, we haven't yet been able to make Narcan available to, but any nonprofit organization can access it.
Wonderful. Thank you for making that distinction. We appreciate it. Okay. So our next question is, presuming you come across someone unresponsive and not breathing, is it safe to say we give Narcan only to the point that the patient is breathing again?
So, yeah. So, I mean, if it's an opiate overdose and you come across someone and you don't know what they took and you administer Narcan, basically, I mean, you administer Narcan and you call 911. Transfer the care of that individual to EMS when they arrive. You are trying to restore breathing in that individual. Some EMS will restore breathing and not, you know, fully revive someone until they're at the hospital. I mean, there's all different ways to do it. But in a community setting, you would want to revive that individual. It is most important that they are breathing, but transfer the care of that person to EMS when they do arrive.
Okay. And I think we had, there may have been one more. Okay, this is an interesting one, and we'll let this one be our last one. Is there any euphoric effect from taking Naloxone if it's not needed?
Good question. No, Naloxone is not psychoactive, meaning it has no euphoric effects. It does not get somebody high. Its only purpose is to reverse an opiate overdose. So if someone were to administer Naloxone to themselves and they have no opiates in their system, literally nothing happens, complete waste of the medication. There's no harm that will come to you of doing that, but there's no benefit at all. So it's certainly not something that people would be seeking out to get high from or anything like that. And then if you do purposefully administer it to yourself and you are using opiates, you would put yourself in a withdrawal. So that's also not something that people really do.
Thank you. Now, Amanda, if you're ready, I'm going to take control back over the presentation, and then I have a couple of technical follow-up issues with our participants, if you're ready.
Sure. Thank you.
Thank you. All right, so we have had a lot of questions. Thank you so much to all of the participants and all of your great questions. Let me go ahead and address sort of a common question that I also saw. There's a lot of interest in the recording of this particular presentation. Do be aware, like all of FADA's webinars, it will be available on our resource center. And we'll have that posted probably within 3-4 business days, something like that. And of course, I know the recording is super important because it captured all of the questions, but also we'll be making available a PDF version of the PowerPoint, and that will just be emailed to the participants as well. Okay, so as we wrap up, just a few points. First of all, Amanda, thank you. That was great. We really appreciate you sharing your expertise with us today. And also, I just want to say thank you for the participants. We had well over 500 people participating today, a really great turnout and on this important, subject. Now, when I end the webinar, you, the participants, your browser is going to take you to an evaluation form. And you'll have an opportunity to complete that evaluation. And remember, completing the evaluation is important so we can give you your continuing education credit and get you your certificate of attendance. However, if you have trouble getting to that webinar portal right after the conclusion of the webinar today, you're going to be getting a second opportunity via an email message from us later today. So you'll be getting that with a link into the evaluation as well. And then, of course, you can always call the FADA office, and we can send that evaluation link to you, if you need that. And again, as we bring this in for a landing, thank you all for participating. It was a great topic. And I also want to thank the Florida Department of Children and Families, the Office of Substance Abuse and Mental Health for funding for today's webinar. So everyone, as we log off, have a great rest of your day and hold for the evaluation.